We'll go ahead and get started. Once again, everybody, my name is Leanne Foster, and I am a provider outreach and education specialist here at WPS. And welcome to today's study hall on split shared services. So if you've been joining us for the last few study hall and back to school sessions that we've been doing, this is our two-part series on split shared services. It includes study hall, which is today, which is going to go through a lot of the basics, some policy information, and some examples of split shared services. We will be answering questions today as time allows, and we'll get to that in a second. However, tomorrow, Ashley is actually going to also be providing part 2 of our back to school series on split shared services, and it is going to be the pop quiz, talking about the denials, rejections, and how to pass those. So as we go through today's session, some questions may be incorporated into tomorrow's session. Now we do know that these two-part sessions are both an hour long, so they do mean that you'd have to spend 2 hours in our sessions. And that may not be something that you can do in real time, given your work activities that you have on a daily basis. Just want to let you know, we are recording today's session. We are also recording Ashley's session tomorrow. So if it would be easier for you to attend at a different time, you'll have that option available to you. So just a little bit of housekeeping before we get into the material. Training material today is available. It is the slide deck that I'll be presenting to you today. That's available on our live events page, and Ashley has put a link to that live events page in the material, or excuse me, in the chat. You're looking for that training material link, and that'll allow you to download the slide deck for today. Also, as I mentioned, Ashley has her pop quiz, her interactive Q&A session tomorrow. If you've not yet registered for that, I highly recommend that you would sign up for that if your schedule allows. You will also, again, as I mentioned, we are recording this session. This will be available as an encore presentation as soon as possible after this session, barring any technical issues. That's usually going to be up and running within a week or so of today's session. They will be available there for 60 to 90 days without you needing to access our YouTube channel, in case YouTube's not something that you can access at work. After those 90 days, this recording will be available on our YouTube channel indefinitely, as long as it is accurate and relevant. Questions today. I did receive quite a few pre-submitted questions for today's session, and I thank you to all of you that submitted those. Great questions, some great examples were sent in. We've incorporated those into the session as much as we can today, and we will address those. We'll also address questions in chat if time allows. If we do have more questions than time allows today, I am going to be creating a follow-up document and sending those questions and answers to all participants for today. Also, we will work to incorporate any unanswered questions into Ashley's session tomorrow. We would also like to hear from you. We know that today you're getting a survey for everything, and sometimes it's really easy to go blind to those surveys. I understand that. It happens to me as well. However, we would really appreciate some feedback from you. This two-part series is something new that we're trying, and we want to hear from you. What's working? Do you like these sessions? Would you like them structured differently? What did we do well today? What could we do better? And also, are there other topics that you would like us to offer either in this format or in a regular format or a different format? We'd love to hear all of that. Your feedback truly does help steer the direction that we take our education. So I want to thank you in advance for taking some time to provide us with that feedback during that survey later on today. All right, one more disclaimer. This disclaimer is just letting you know that the material presented today is accurate as of today. And if you've worked with Medicare for any period of time, you know that Medicare rules and regulations change, and they change often. So please be sure that you continue to monitor official CMS and WPS websites to make sure that you're following all the most up-to-date Medicare rules and regulations. Also, CMS does prohibit the recording, screenshotting, or photographing of this session for profit-making purposes. And as I stated, we are recording the session, so this will be available to you if you'd like to see it again, have questions, or know of someone who maybe couldn't attend today that would find this session valuable. That brings me to our agenda for today. So our goal today is to provide you with an understanding of Medicare-specific requirements for billing split shared services for evaluation and management services. So as part of that session today, what we're going to do is provide a definition of split shared services, including the definition of a group for split shared services, because that is a little bit different here. We're going to also review how to determine the billing provider. A lot of our pre-submitted questions had a lot to do with that. We will also talk about general billing requirements for split shared services, including modifier FS, as we did get quite a few questions about how to use that. And finally, we are going to talk about how to document split shared services. And I would say this was probably the single most pre-submitted or often asked pre-submitted question that we received, were questions regarding documentation. So we have included some examples today. We've also included some do's and don'ts that'll hopefully help you with that. Now we did also, before we move on, we did also receive some questions regarding Incident 2 services. And we're not covering Incident 2 services today. I call this out because Incident 2 and split shared are different. They're similar, there's some similarities, but they are different. And we find that providers often have questions about that. Now, last week we did do a two-part webinar series that was specific to Incident 2, and those recordings are available on our Encore page this week. They are already live on our YouTube channel. They should be posted in the next couple of days on our Encore page. So if you'd like more information on Incident 2, I'd encourage you to go out there and take a look at that. I will be using a handful of acronyms today, so I did include that in your information, your presentation for today, in case that information is helpful to you. Which leads me to where we want to start. So I wanted to start with an overview of split shared services. So split shared services are E&M visits in a facility setting where both a physician and a non-physician practitioner, an MPP, are performing a portion of the visit. Now, by facility setting, we are talking about an institutional setting, and we will be talking more about that later on in the presentation, and I will provide some specific examples. But this is one of the biggest differences between Incident 2 and split shared. Incident 2 is for non-institutional facilities. Split shared is for that institutional facility. Also, the physician and the MPP that are providing those services need to be in the same group. Now, I just said that I'm going to talk about the definition of a group for split shared services because it is a little bit different. And we will talk about what same group means in a minute, because like I said, it is different and you may not be working for the same entity, but be considered part of a group. So reimbursement for split shared services is only going to be made to one provider. I just mentioned that both the physician and the MPP are providing the services, but only one of them is going to be billing. And when you're billing for split shared services, it's going to be based on who provided the substantive portion of the service. You're going to bill under the provider that provided that substantive portion. That substantive piece is key here. And so I want to show you a couple of resources that are out there that will help you define that. So there's a couple of places. Sorry for that flicker. There we go. I'm going to start with the Evaluation and Management Services Guide. There is a section here that is, and pardon the scrolling, that is specific to split shared services. And here they have recently made some updates. So this was offline for just a period of time. I'm going to go ahead and actually put a link to this in the chat. It wasn't included in your materials for today because they were making updates and we weren't sure it would be published for today. But here what you're seeing is a chart that contains the definition of the substantive portion of E&M visits. And you'll see that it's talking about other outpatient visits, inpatient, observation, hospital and skilled nursing facilities, emergency departments, and critical care. And this will be a really helpful tool for you as you're billing those services in determining what CMS considers the substantive portion. This chart is also available in the IOM, or that Internet Only Manual. So I clicked on the wrong thing. There we go. The internet-only manual, it's in the claims processing manual, and I'm going to take you to Chapter 12. I have provided a link to Chapter 12 in the resources section of your training material with various sections, so you will have this. And I am going to jump because I happen to know that it is on page 73. I am going to jump to section 30.6.18 for split shared services. And again, that is provided as a reference in your materials today. But this same chart is also in the claims processing manual so that you have that. So CMS is trying to be as clear as possible about what is considered that substantive portion. So while both the physician and the MPP are providing those services, remember that the provider that's performing that substantive portion, and you'll hear me say that a lot today, is the one that's going to bill for the service, and that's going to be a key piece of this. And we'll have some examples that will walk through that. But I want to call out that it's not always going to be the physician that's going to be the billing provider. Sometimes it is going to be the non-physician practitioner. We got quite a few questions on that, and I'm including some of that into the material further down. But it's not always automatically going to be the physician that bills for the service. The physician may not provide that substantive portion, and therefore it would need to be billed under that nurse, that non-physician practitioner. And this is something that is going to be based on the documentation, and we'll talk about that a little bit later on, but the documentation does need to support who billed for the service. So let's look at who can provide split shared services and who can bill. So again, split shared services can be performed by a physician or the MPP. However, there are requirements to keep in mind when they're performing those services. Both the physician and the MPP must not only be able to perform the services, so they're licensed, it's within their scope of practice to provide the services that they're performing, but they also need to be able to bill for the service. Again, this is also where it's a little bit different than incident 2. I'm making some comparisons, even though we're not diving into incident 2, but with incident 2, your ancillary staff may not be enrolled in the Medicare program. Here, they're going to need to be enrolled because you may bill under the physician or the MPP, and it's not always going to be that physician. So it's a little bit different here. Split shared services are for services that both the physician and NPP could have provided and bill if they provided them independently and the other wasn't involved. So that just means the patient could have just seen the physician and they would have billed. They could have just seen that MPP and they would have billed. They both see the patient, they're going to bill under one of them, but they both have to be eligible to bill in order for you to be able to select that billing provider appropriately. So you do have to be careful of visits here that also are required to be provided by the physician. For instance, there are certain skilled nursing facility visits, that initial assessment that are required to be billed by the physician. And those services are outlined in that Medicare Claims Manual, Chapter 12, in Section 30.6.13. I have also included a reference to that or a link to that in the resources section today so that you have that. And then also, as we mentioned before, they're going to need to be in the same group. But again, same group means something different than typical, and we'll go into that in just a few minutes. So as we said earlier, split shared services can only be performed in a facility setting, and I mentioned that we were going to talk about that. So what do we mean by a facility setting? So CMS defines a facility setting as an institutional setting in which payments for services and supplies furnished under Incident 2, a physician or practitioner's professional service, is prohibited. So if Incident 2 is something that you could bill, because it's going to be that typically it's going to be that non-institutional, typically an office service. That's not going to be a scenario or a facility where a place where split share is going to be billed. So we're talking about an inpatient hospital or place of service 21, an outpatient hospital, which could be a place of service 19 and 22. We're looking at emergency departments or place of service 23. Split shared's also possible in an inpatient observation setting. We do have a couple of additional settings, including a critical care setting. And we'll go into a little bit more detail on critical care and split shared services in a minute. And then also skilled nursing facility 31. But again, you have to be careful with skilled nursing facility in case it's a service that by law, the physician must provide the service. And again, I'm talking about that initial comprehensive visit or assessment here as an example, but you want to reference the claims processing manual. And again, I'm giving you that reference just to be sure that you're in line with that. So the other thing I want to call out here with SNF is that it can be a little bit different. You'll hear us talk about skilled nursing facility and nursing facility. They're not the same thing. So the skilled nursing facility is different because if it's a skilled nursing visit, it's in a Part A stay. Part A is still covering it. They can be in a nursing facility and it is billed as a straight nursing facility or that place of service 32. And when that's the case, that is an eligible facility for incident 2 when they're in a Part B stay for a nursing facility. So that's something to keep in mind there. So we've talked about what's considered a facility. Now I want to dig further into that group. I've mentioned it a couple of times here. And typically, a group is defined as providers that are practicing under the same tax ID with the same specialty. CMS defines that in multiple places. However, it's not the same for split shared. So in the case of split shared services, you, meaning the group, the provider, are going to decide what is considered a group for split shared services. So how you define that group is going to vary. It's not necessarily going to be based off of tax ID or specialty. So here I wanted to give you a couple of examples what's considered a group. Now, while I said it may not be the same tax ID, it could be that a group is the traditional definition of a group, which is the same tax ID, or we've got the same specialty and we have the same specialty going on. But where it varies, maybe you have a collaboration agreement with practitioners at the facility where you're providing the services. Maybe you're a provider that's typically working for ABC Clinic, but you have a collaboration agreement with XYZ Hospital. Maybe there's a contract in place. The point here is that the group may be providers not necessarily employed by the same entity. We have heard of situations where a group of cardiologists is involving hospital-employed MPPs. The cardiologist isn't employed by the hospital, but they're involving hospital-employed MPPs in patient care for their patients. That is okay, but there would need to be a contract or agreement between the cardiology group and the MPPs that has to define reimbursement. So both the doctors, the physicians, and the MPPs will need to be enrolled. The services will need to be in their scope of practice, and they need to be able to bill for Medicare, but not necessarily under the same tax ID. Remember, you're only going to be billing one. But the parties involved in the group, and you can't see my air quotes when this is the case because they're not part of a group. It's not going to be obvious that they're part of a group. The contracts in that scenario have to outline how they're going to distribute the reimbursement. So you're only billing under the physician or the MPP. So if they're not part of that same tax ID, your contract has to show how that split payment works. If you're submitting under the rendering physician for the substantive portion, if the physician is submitting, how's the nurse practitioner going to be reimbursed for services? They can't bill for them. And vice versa. If the MPP is billing for the substantive portion, they're the billing provider, how is the physician or the MD or DO going to be reimbursed? And again, this documentation needs to be there and be provided if requested by Medicare. It's going to have to outline that. So next we're going to move on to the billing requirements for split shared. Starting with just some general guidelines. So like anything else, to be billed a split shared service, the services performed do need to be covered by Medicare, and they do need to be medically necessary as outlined in the Social Security Act. And you'll have that reference in your resources section as well if you want to look at that. I have included that link. It must be in an approved location for split shared services. So this means the facilities that we just talked about, it does need to be in that approved location. And I keep talking about documentation, and I'll continue to talk about documentation, but the documentation must support the services and show who did what, because it does need to support who provided that substantive portion of the service. And again, we'll talk about how to do that here next. You'll also need to make sure that you're appending the appropriate modifier. And the only modifier that's used to identify split shared is FS, and we'll talk about appending that to your claims here in a minute. But it is an informational modifier. It's letting us know that it was billed as a split shared service. And then the payment level, we're talking about a physician or MD and DO and a nurse, non-physician practitioner here. So if it's billed under the physician, it's paid at 100% of the fee schedule. If it's billed under the NPP, it's paid at 85%. And again, I'm going to come back to that documentation. You can't just choose the physician because it's reimbursed at the 100%. You do have to look at that documentation and see who provided the substantive portion of the service, and that is where you will bill. So determining the billing provider is arguably one of the more challenging pieces, and we did receive questions on that. So you can choose which practitioner you're going to be billing under based on time or MDM. You're using that to also determine your level of service. So time is usually the simplest of them, right? So if you're choosing time, each practitioner is going to document their time that they've spent providing care to the patient. Now, they will both need to document their time. And we'll talk about that, some specific examples of that in a minute. But make sure that when you're doing this, you're including both face-to-face and non-face-to-face time. If you spent time after the encounter on that same date of service, coordinating care, if you were ordering tests, if you were organizing interventions, that coordinating interventions, that kind of thing, count that. That's work that's been done, but make sure you're documenting that time for the practitioner, whether that's the physician or the non-physician practitioner. Document who performed that. And then based on that, you're going to determine who that billing practitioner is, who provided the substantive portion of that time. Now, at least one of the providers must provide a face-to-face service. It's not necessarily going to be both of them that are going to provide the face-to-face service, and the person that or the provider that provided that face-to-face service may not be the billing practitioner. It is possible the provider who did not provide the face-to-face service actually provided the substantive portion of the service. But again, documentation does need to indicate that. That documentation also needs to indicate which of the practitioners, whether that was the physician or the MPP, provided the face-to-face service. So not only who provided the substantive portion, but who provided the face-to-face. Needs to document everything that happened in that encounter. Also, you need to make sure that you're only counting time once. So we did get a question on this. It means that if question on this as far as if an MD and a DO and the MPP meet to discuss the patient's care, do we count that time under both or just the one? So it's a really excellent question. That time is only going to count once. So document the time under the MD/DO or the MPP, just not both. And then that time is used to determine the billing practitioner. You will need to make the decision of who you're going to document that time under, but you're only documenting it the one time. So it just needs to be clear. The other thing that I want to point out is you need to document the specific time. We'll get this question a lot. Can we make a statement of we spent more than 15 minutes? It's not your best practice. If you spent 17 minutes with the patient, document that you spent 17 minutes with the patient. Now, we're not, as you've probably heard me if you've attended any of my sessions before, we're not asking you to stopwatch yourself. We don't expect the providers to do that, but it should be as accurate as possible and not a range and not a, as I mentioned, the more than 15 minutes. It needs to be more specific than that. The other question that we got was about sign-offs, and I'll mention this in a couple of places. We did get asked if the physician signs off that they agree with the services the nurse practitioner, the time the nurse practitioner spent. Is that appropriate? And that is not. So those sign-offs we'll talk about a little bit more as we get through this, but it's not just that signing off. You do actually have to document the time that they spent on patient care. So I mentioned that it includes both face-to-face and non-face-to-face service or activities. So if you're preparing to see the patient, that counts. That's work. That's non-face-to-face time. Obtaining or reviewing a separate history, that counts. Performing the exam, this would be that it may or may not be face-to-face, just depending on what that exam looks like. Counseling or educating the patient, the family, or a caregiver, that counts. Ordering medication, tests, procedures. A lot of times this is something that happens post-encounter, but on that same date of service. Count that time. You put in that work. We did get a question about a phone call to the patient and they didn't answer. If that was part of one of these activities, that time would count. Now, I wouldn't expect it to be a terribly large amount of time, but if it's part of one of these non-face-to-face activities, that would count. Referrals and communications that are not going to be separately reported. So none of, if anything that you're doing in any of those referrals and those communications, if that's going to be billed separately somehow, it can't be included in this service. That's double dipping. So just make sure you're not including items that would be billed separately, different code, different provider, what have you. Make sure that's not being included. Time documenting that encounter, that counts. Independently interpreting results. So if you're independently interpreting, say, radiology reports, if you're just reviewing them, but not interpreting them, that does not count. But if you're doing an independent interpretation and you're making medical decisions based off of your interpretation and there's a report that you're creating for that, that counts. However, if you're reviewing something that's being separately reported, that's not going to count. And then care coordination, again, you want to make sure it's not being billed separately, but if you're doing care coordination that's not, that counts as not face-to-face time. So some do's and don'ts. I've mentioned this a couple times. Document time spent. You want to document the time that is spent by both the MDDO and the NPP. You want to make sure that you clearly indicate the amount of time. And a good example would be what I have here. I provided 30 minutes of care for services for this patient. That would be an acceptable statement here. General statements are what you need to stay away from. They're not your best practice. Statements like, I provided the substantive portion. Okay, show us what you did. We need to see the work, the proof of thought or the amount of time. You can't, it's not good enough just to say you provided the substantive portion. It has to be clear. I know this is stating substantive portion, but how do we know that? How was that decided? Also want to stay away from a statement such as, I provided the most time. Again, it's not specific enough. We need just more detail. We need to know what that looks like. So now we're going to look at how you would select the billing provider based off of medical decision making. So this is again going to need to be documented by the MDDO and the NPP. They're going to need to state which pieces of the medical decision making that they provided. Now, we don't want, normally we're not asking providers to redocument anything, but it has to be clear in the documentation for split shared services who performed what as part of the MDM to make sure that it's clear who provided that substantive portion. So we're looking at who completely performed which MDM elements: problem, data, and risk. And the provider needs to complete the element in order for that element to count towards them. So they may both be working on all three pieces, but obviously one's going to complete the element. There may be parts where their paths cross, but who completed the problem, uh, who used the data to analyze and create that MDM, and who assessed that risk to the patient. Sorry, that just locked up a little bit. So let's talk about documentation with MDM a little bit. So the do's. So who provided which elements? Like I just said, who did the problem, who did the data, who did the risk. I performed a portion of the MDM. Now, I make sure you identify the portion. I put A in there more as a placeholder, but I performed the data portion of the MDM. I performed the data and risk portion of the MDM. Just make sure that's included. So we're not asking for much more of a statement, but we're looking to have it clearly identified in the documentation. This again is coming up, general statements. This came in several times where I reviewed MPP notes and agree. That is not acceptable. In fact, one of the questions that we received was, the nurse practitioner sees a patient in the hospital today. The next day, the physician makes a note that they agree with the MPP's note from yesterday, and the physician states they performed a substantive portion of the MDM and gives their interpretation. The question is this considered a split shared service? And can that MD be the billing provider? In this case, we'd certainly have to look at the notes, but just saying that they agree with the MPP is not performing the substantive portion. They need to tell us what portions that they performed. Again, it's going to feel a little bit like double documenting, but just saying they agree is not performing that service. So keep that in mind. So some general documentation information. So if you're billing under, we get questions about the signature. So both parties, let me step back because I started with signature first there, sorry. So the billing practitioner, so who's going to be the billing practitioner is the one that needs to sign the documentation. It's certainly not a bad practice to have them both sign, but the billing practitioner does need to sign and date that. And that is something that we will see in our cert errors as far as someone had asked about some of the most commons, and sometimes it is who's signing and dating that documentation. So make sure that the billing practitioner is signing those. Now, both parties do need to document their activities, whether it is the time or the elements of service that they provided. So make sure that that's clearly outlined. So I want to look at a couple of examples because I know this can get a little tricky. And with example 1, the scenario is nurse practitioner Gray spent 10 minutes with Bruce beneficiary in the hospital. Later that day, Dr. Green spends 15 minutes with Bruce to discuss treatment options. So the total time for the service is going to be 25 minutes. The nurse practitioner spent 10 minutes with the beneficiary, and the physician spent 15 minutes. So trying to keep these a little bit straightforward just to get help with base understanding. But in this case, this is based on time, and the physician, the MDDO, spent the substantive portion of time, so the billing provider is going to be the physician in this case. You're documenting both the portion of the service that the MPP and the MD and DO provided for Bruce beneficiary, but you're billing under the physician. And then again, the physician is going to have outlined how they're going to reimburse the nurse practitioner for their services. Example 2 is going to be time as well. We do have an example here for MDM. So in this scenario, nurse practitioner Gray spent 10 minutes with Betty beneficiary this time in the hospital. Later that day, Dr. Green spends 15 minutes with Betty. Nurse practitioner Gray and Dr. Green spent about 5 minutes to discuss treatment options. So this would be that joint time. So your total time here is going to be 30 minutes. Nurse practitioner has 10 minutes of time specific to their services. The physician has 15 minutes, and they have an overlapping 5 minutes of time. That overlapping time counts once. Now, it is going to be your business decision where that time is going to go, but looking at this example, if you give that 5 minutes of time to the nurse practitioner, you're going to have equal amounts of time. And that's not, nobody at that point is providing that substantive portion. So here you'd likely decide to give that overlapping time to the physician. They're already the substantive portion. They'll have 20 minutes. So then the billing provider becomes the physician in that scenario. Example 3, we get questions on the MDM. So here we've included this, and we've gotten a couple, and this is similar to the questions that we got. So in scenario 3, nurse practitioner Gray obtains history and performs a physical exam for Bruce beneficiary in the hospital. Dr. Green reviews outside labs, imaging, and test results. So that's their data piece. And then Dr. Green then develops the care plan and counsels the patient. They're developing the care plan. So in this scenario, they're also assessing the risk to the patient. So here both providers are contributing to the MDM, but Dr. Green provided the substantive portion of the MDM because Dr. Green completed the data element and that risk element. So in this situation, the billing provider would be Dr. Green. All right, so let's go back to billing requirements. And actually, I am going to pause there because I'm just looking at the chat. I see a couple of questions have come in. And I think some of them are specific to the examples. So Ashley, can I check in with you for a second and see if we have any questions that we want to address at this time?
Yeah, I'm so glad you asked that. Actually, the first question that came in, I think, relates to the example that you just gave on slide 23. This question states, oh, not that one, sorry, let me scroll back up. Here we go. So this one says, the example given for MDM is very clear cut. However, in practice, it rarely is that clean of a situation. How would you view the following example? Nurse practitioner Gray performs and documents the history, exam, data review, and assessment and plan. Dr. Green reviews the nurse's notes, including labs, imaging, test results, etc. Dr. Green documents, case was discussed with the nurse practitioner, agree with plans and findings, and then summarizes, oh, hang on just a second, I lost it. And then summarizes and repeats the information in the nurse practitioner's note. Does WPS consider it to be the physician's work if they discuss the information with the nurse practitioner and agree/approve the plan? Who would be the billing provider in this example?
And that's an excellent question because you're right, it's never quite that cut and dry. So what I would say to that, it's going to be what the documentation supports. The documentation has to show the proof of thought. So as we stated earlier, we want to stay away from blanket statements that are saying, I agree with. They have to show what they did. If they're just agreeing with, it doesn't necessarily substantiate that they completed the work. It's going to be different for every scenario, but it's really important that they're showing that they did the work. Now, the second part of that question, you did indicate that they were documenting their interpretation of that. That might be something that would substantiate that that physician did more work. However, without seeing that specific documentation, it's not a yes or no that I can give here, but it's that blanket statement that's causing the most concern because it's not really showing the work.
All right, Leanne, we had a couple other questions, and I don't know if you want to take those now or hold off till we get to your Q&A section.
Let's go ahead and we've got time, so let's go ahead and grab those quick.
Okay. The next one that came in is I audited some records where the nurse practitioner is seeing the patient. The doctor makes a statement similar to the split shared visit comments they make in the hospital, but it is under the doctor. When I brought this up, they were told that the nurse practitioner is just acting as a scribe. Should this be allowed under the doctor? There's nothing in the record indicating the nurse practitioner is scribing, and then they added that this is in the clinic, not the hospital.
Okay, so this is in the clinic and not the hospital, so it doesn't sound to me like it's necessarily a split shared service. Also, if that nurse practitioner is the scribe, certainly they can be that scribe, but then are they performing the service? So it doesn't sound like they clarified that for you, but that documentation really needs to support who provided the actual services in order to determine that billing provider.
All right, and we had one last question that I've not been able to get to yet, which is if the non-physician practitioner and MD discuss and create the plan together, who gets credit for it if it is documented by the NPP that the plan was developed with Dr. X, and then the doctor documents, I review and agree with the NPP's note.
So again, you're going to want to stay away from the I review and agree with the MPP's notes. It's going to need to be clear in those notes who provided that service. They both provided it. It sounds like it's part of similar to our overlapping example in our second time example. And so you're going to need to decide who's going to get credit for that. If they both provided it and it's overlapping, you can decide who's getting credit for that time. But then that provider is going to need to have documented that time. All right. I'm sorry, Ashley, go ahead. Are we okay?
No problem. I was just scrolling back down to see if we did have a few more questions come in the meantime. Do you want to take those now, or do you want to hold off till we get to that section?
Let's hold off until we get to that section. I want to make sure we get through everything, and I want to be cognizant of everybody's time, but rest assured I am checking in with Ashley one more time for questions. Thank you, Ashley. So back to the billing requirements. So modifier FS, we did receive some questions about this. Modifier FS is required for split shared services. This is going to show us that that physician, that MDDO and MPP are working together to provide the encounter to the patient. So it's regardless of whether you're billing under the MDDO or the NPP. It doesn't matter who the billing provider is, but the FS has to be there to show us that this is indeed a split shared service. So keep that in mind. It's also an informational modifier, so it's not going to change how the service is being reimbursed. That's going to be determined off of the typical information. Who's the billing provider? What's the place of service? What's the address? What's the fee locality for that? That's why I get into the address piece there. What's that fee locality? And remember, it's going to be billed or reimbursed at 100% if the billing practitioner is that MD or DO, and the 85% if it is that NPP. But again, it is informational and not changing how that claim is paid. But it's important to append that. That is how we know that this was a split shared service. The other thing that we get questions about are prolonged care. So split shared also includes any prolonged care. So this is choosing your code based on time. Prolonged care is not something that impacts anything that is based off of MDM. And you're going to use the time provided by each practitioner to determine that billing practitioner. I do want to call out, though, that prolonged care is not going to apply to critical care and emergency department because their billing is just a little bit different. Emergency department level of service is not chosen by time, it's chosen by MDM. You're only going to choose based on elements of service or MDM, but you can use time to choose the billing provider. Now, in an emergency department, if you've attended my session on that, I talk about how hard that is to keep track of that time. So the likelihood of using time to determine the billing provider is probably not frequent. But again, level of service still needs to be off of medical decision making, not time. The billing practitioner is what could be determined off of time. But again, it can also be determined off of medical decision making. And then critical care came up as well. So this is going to be a time-only service, and it does include those face-to-face and non-face-to-face services. Again, here both parties do need to document time. We do get questions about an over midnight and that time. Now, it has to be a continuous service. If there is a break in the service, then you're starting it's a little bit different. Your service has been interrupted, so it's not part of the same service. But both parties, again, have to document the time, and you do have to use the time to choose the practitioner. You're not using MDM here. Okay, so as promised, I'm going to check in with Ashley, see if there are any other questions in the chat, and I know we have a few.
All right, we did have a few more come in. The next question we have is, what if both providers spend exactly the same amount of time?
So if they're spending exactly the same amount of time, you really don't have anyone who provided that substantive portion of the service. So you really want to look at that. Is there any overlapping time that maybe could be credited to one or was credited to both that should only be accredited to the one? Substantive is the key here. And if we go back to, let me go back to those charts. CMS is defining substantive portion as more than half of the total time or more than half of the substantive portion of the MDM. So in order for it to be billed as split shared, there has to be a substantive portion provided by either that MDDO or that nurse practitioner. Split shared isn't just defined by, it's a service that's performed by both the physician and the MPP, but one of them is performing that substantive portion. That is the key piece.
All right, our next question is, do they have to perform 2 out of 3 elements of MDM to be considered substantive portion?
Well, in order to get credit for the element, they do have to complete the element. So it would be the 2 out of 3 to show that substantive portion. Somebody's going to have the substantive portion of each element, and then they could get credit for completing that portion. So you really have to look at the documentation and see what it's telling you.
All right, our next one is, would this attestation be accepted by WPS for split shared leveled by MDM? And then it says, this service was delivered by an advanced practice provider and a physician. The physician performed the substantive portion of the medical decision-making used to level the service.
So I would not be your best practice. As I was saying in the MDM portion of this situation, you want to identify the elements of MDM that they included. Now, if they include that in that, that's going to be more clear to a reviewer. So they do need to tell us what they did. Again, proof of thought. What was the substantive portion? Did they do the data and the problem? Did they do the problem and the risk? What actually occurred? Those blanket statements are really not the best practice. They have to be specific. We need to know what occurred in that encounter.
All right. The next question is, oh, you've already kind of answered this. If this one says, if equal time or equal MDM, who is the service billed under, the MD or APP?
Yep. Remember, split shared, there has to be a substantive portion.
All right. Our next one is, the NPP sees the patient today and provides her note. The MD reviews her note the next day, and he provides the substantive portion of the MDM. Does this count if his documentation is dated the next day?
We're looking at the services to be provided the same day. It'll be when he provided that substantive portion. I'd have to take that one back to see if the attestation is dated the next day, but if they're providing those services the next day, it's not really happening at the same time. I can take that one back and get some clarification from our medical review area to see if that is something that's acceptable. So I will get that back out to you.
All right, and one moment, let me scroll back to the next one. The next one is, can you repeat the time in regards to critical care? So if the critical care time starts Monday night at 11:55 p.m. and documented as such and overlaps to Tuesday morning at 12:45 a.m., the date of service wouldn't be billed for Monday with the cumulative time?
So critical care is a little bit different in how you determine its date of service. It has to be continuous care. And even if it goes over that midnight, it's going to be when that time started as that date of service. So, and that's going to impact some of the questions that we're getting about the provider's attestation overnight, not knowing if some of those are specific to critical care or not. But it has to be that continuous service to count as that same date of service.
All right, we have just a few more questions left. The next one is, in previous webinars, WPS had stated that if their notes were equal for either time or MDM, we could choose who to bill that under.
You should still be able to see who has, you'd have to look at those documentation again and look for the substantive portion. I'd have to go back and look at that previous education.
All right. We have two more. Oh, nope, I'm sorry, just one more. If critical care is provided continuous across midnight, would all the charge service be for the started date of service?
That is correct.
All right, and it looks like that was our last question, Leanne.
All right, excellent questions, everybody. Again, I am going to check on that one for MR with the sign off on the next day. If there's additional information on that one that you'd like to submit, you can throw that in the chat or you can send that to that educational mailbox, but I will get that sent back out. So I have, as I indicated, included some resources for you. And here you have a link to our WPS website that's talking about correct billing of split shared services, along with the Medicare claims processing manual references that I referenced during the session. I've also included a Code of Federal Regulations link and the Social Security Act. Code of Federal Regulations link is going to talk specific to split shared services, and the Social Security Act is with regards to that medical necessity. So in a few minutes, you are going to get an email that is thanking you for attending today. Don't delete that without looking at it. If you are attending today for continuing education credits, this is going to be your certificate of achievement. So in this email, there's a couple of things. There's a portion with a link to our survey, but at the bottom, there is that certificate of achievement, and that has the date of the session and the contact hours. This can be submitted to your accreditation or certification body in order to count towards your education units. So that is not going to be a CEU in and of itself, but it's something you can use towards those CEUs. So if you didn't get this, a couple of things may have happened. One, this email comes from our webinar software, it comes from WebEx Messenger, and if that's not added to your safe sender list, it's going to go to junk or spam. So check there. Also, if you attended via phone, I don't have a systematic way to confirm your attendance, and I can't trigger this email. So in either situation, send us an email to that education mailbox. Let us know that you need your certificate of achievement for today, including the phone number that you attended from, and I will go ahead and get a certificate sent out to you. This is a topic that generates a lot of questions. We welcome those. So I am going to be taking questions for the next 7 days, and we will get back to you on those questions. So you will get responses. This isn't your last opportunity. Also, as I mentioned, we are going to try and incorporate as many of these as we can into Ashley's interactive Q&A session tomorrow. So a couple of ways of submitting those questions. One, still have a little bit of time in the chat. We will look at those. Also, email those to our education mailbox. Ashley's putting a link in the chat for you. And you will want to include the topic of today. If you just did split shared services, that'll get to Ashley and we'll get those questions answered. If you have the training material, there's a link on this slide that will open up an email with that already pre-populated just to make it super easy. So go ahead and send those to us and we'll get those sent out to you. Just a reminder, if it is a claim specific question, that does still need to go to customer service because they have access to those claims and can tell you the history of how that processed and how to move forward. As I mentioned at the beginning, now is your opportunity to provide us with a little bit of feedback. Again, this is a newer style of session and we want to know what you'd like us to continue, what we could do better, what we could do to improve it. How did we do, right? We want to hear that. I know everybody wants a survey for everything you touch these days, it seems. However, we truly do use that. This is our direct feedback loop with you, the provider. We and CMS take these very seriously. So again, thank you for taking some time to provide us with a little bit of feedback. And please include any topics that you'd like to see in the future. So you're going to have a couple of ways to take this. Ashley just threw a link in the chat for you. You can click on that. Or as you leave the session today, you're going to get a pop-up. It's a redirect. Looks like the image you see on your screen towards the bottom with the continue button. It's not junk. It's not spam. It's not malicious. It's not taking you anywhere dangerous or that you don't want to go. It's just letting you know you're leaving our webinar software and you're entering CMS's Qualtrics survey software. So that will come in just a couple of minutes. And just as some examples of how we do incorporate that, direct provider feedback is why we've added chapters to our YouTube videos. So you don't have to scrub back and forth in a video. You can click to just certain key moments that we think would be places you'd like to see. We've also added training indicators to our live events page to help you find the sessions that are going to make the most difference for you. And then also the resurrection of our large events. We're doing large-scale virtual events, referring to them as Medicare Education Expos, and they are going to consist of multiple webinar or events that are going to be focused on one topic. The one that we have coming up in mid-October is specific for new to Medicare. So from start to finish, how the life of a claim, from provider enrollment to your appeals and questions. There's going to be a Q&A session as well. So that's open for registration if you're interested. With that, that is going to end the session for today. I want to take another moment to thank you all on behalf of myself, Ashley, and everyone on the Provider Outreach and Education team for taking the time to attend today. We know that everyone's super busy and sometimes carving out this time can be tough. So we are honored that you have been able to carve out that time and attend with us today. Look forward to seeing you in future events, hearing what you'd like to learn about, and what we can continue to do to support you and what we can improve upon. So with that, that ends the session. Everyone have a fantastic day. Continue to be well. You may now disconnect.